wanted to put together a video with the most common questions I encounter on a daily basis at my office for patients who are considering hip replacement surgery and want to get ready for understanding most of the aspects of the procedure and the rehab. In the office, I tend to share a lot of information and it can be kind of overwhelming, so it's hard for people to really remember everything we talk about. So this will serve as a reference for you after hours. So one of the big questions is obviously why have a hip replacement in the first place? Obviously, you have to be a candidate based on x-ray findings that would show bone-on-bone arthritis. And the other major consideration is how your quality of life is affected. Does it wake you up at night? Are you having to medicate on a daily basis? Does it stop you from doing the things that give you joy? Those are the most important considerations that I find patients have and drive them towards getting the surgery done. This is an x-ray demonstrating a good example of hip arthritis where I've indicated with the arrows the location where the ball is grinding on the socket due to loss of the surface covering protective cartilage on the bone. There are some situations where it's not necessarily clear if the hip arthritis is the major pain generator, as there could be some pinched nerves in the back that masquerade as a hip problem. So in those situations, many times we'll do an injection of steroid into the hip joint as a diagnostic tool and therapeutic maneuver to help differentiate what might be pinched nerve pain versus the hip arthritis pain. So now that you've decided to have your hip replaced, the question is which approach to use. I use the anterior approach, which is the so-called minimally invasive muscle sparing approach, where you go in between muscles through the front of the hip in order to help preserve the stabilizing structures around the hip joint. The advantages we typically see is a faster time through rehab, less pain initially after surgery, and it's just easier after surgery for the patient because there are less precautions in terms of where you can position your leg. The next question that comes up is what the implant materials are made of. This is an example of a hip replacement. The stem, which is the part of the implant that goes into your thigh bone, is typically made of titanium. The shell is also made of titanium that makes your new socket. After we put the shell in, we oftentimes will hold it in place initially with 1 or 2 screws, depending on the surgeon's preference. Inside that metal shell, there is usually a plastic liner. Then the new ball is put onto that thigh bone implant. And what that ball is made of is typically either ceramic or metal these days. The ceramic ball on the plastic liner we think has potentially longer duration and lower wear rates, so it could last longer for people. Here's an x-ray taken after surgery demonstrating the new ball and socket in place. The major risks of having hip replacement surgery are blood clots. In order to minimize that risk, the number one thing you need to do is get up and walk. So the sooner you're up and moving after surgery, the better. Another risk is infection. That's probably around 1 to 1.5%. It's tripled in the case of diabetes in some studies. So we give antibiotics through the IV during the surgery and for 24 hours afterwards to help reduce that risk. Another risk is dislocation of the artificial hip. Through the anterior approach, it looks like there's a much lower risk of dislocation, perhaps about 0.2%. There's a risk of a leg length difference. Sometimes in order to gain stability of the implants, you have to lengthen the leg in order to tighten the muscles around the hip joint. Now, I find that it's extremely rare that needs to be done through the anterior approach because it is such an inherently stable way to do the surgery. Another risk is numbness around the incision site, just to the outer side of the incision site after the anterior approach. It doesn't affect your strength, and it may not even be there forever, but I do warn people that sometimes they'll have a patch of numbness next to the incision. Now, anyone who is obese, smoker, or diabetic, all of these risks are increased, and so one of my primary goals for patients is to get their weight down before considering surgery, ideally a BMI below 38. So what do we do to help prepare for surgery before the day of? Well, number one is try and get as fit and strong as you can, because that'll make it much easier for the rehab. Now obviously this is difficult when the hip hurts. Exercising is one of the few things that you want to do, but the more you can do, the better. We also want to try and get completely off of any narcotic medication. That can make it much more difficult if you're on narcotics to control your pain after surgery. So that's another big goal we have. We want you to stop any blood thinners about 1 week before surgery, because that does increase the risk of bleeding after surgery. The other thing we want to do is get basic blood work, which usually includes an EKG, a chest x-ray, and electrolytes and blood counts. If you have multiple medical issues, then oftentimes I'll ask the primary care physician or the cardiologist do what we call preoperative risk stratification. It's basically sort of a medical clearance to make sure that they think you're okay to go for surgery in terms of your heart and lung health. About a week before surgery, I will send in your pain medications and we'll make sure that you have a walker or crutches, depending on what your needs are. So what happens the day of surgery? Well, you're going to get up early. You don't eat anything or drink anything after midnight the night before, so we get to torture you that morning. You do get an IV when you get to the hospital, so we have a chance to replenish those electrolytes you're losing. You'll get to the hospital and they'll have you change into one of those gowns that I think hasn't changed since about 1950. So you put it on, it covers your front, but fortunately you're behind closed curtains and you get right into the gurney and put warm blankets on after you get that on, so that won't be for long. The anesthesiologist will come chat with you about how they're going to keep you comfortable during the surgery. By far the most common way we do that is to have a spinal anesthetic, where it takes them about 5 minutes before the surgery. They inject your back with numbing medicine and it numbs up your legs for about 3 hours. So that way you don't have to go to sleep if you don't want to. They can just have you sort of in a twilight sleep and perfectly comfortable while I do my work. The other thing we do is called site marking, where I will come discuss which part of the body we're doing surgery on and use a marker to put my initials on that site. I always warn people that I'm going to ask you as though I don't know, because I want to hear it from you the day of. In the operating room itself, there is a special bed that we use for the anterior approach surgery that helps facilitate safer and more effective access to the bones. You'll also notice there's a live x-ray machine that we use, and that helps us with the anterior approach in particular to dial in and make the leg lengths as symmetric as possible during the surgery. The surgery itself will take about 1 hour, and then you'll be in the recovery room for another hour. After that, you'll get taken to your room where the physical therapist will come chat with you. That day it's ready to get up and go, and if you and the physical therapist and the nurse feel like your pain is controlled and you're getting around okay, going in and out of the bathroom, up and down the hallways, then you could leave the same day of surgery. Many people stay one night just in case they're feeling nauseous or otherwise need another night to help recover. My incision doesn't have any staples or stitches on the outside. Everything is dissolvable and it's covered with a waterproof dressing, so I let you get in the shower on day one if your strength and balance are safe enough to do so. You'll be discharged home typically with home health care, which is physical therapy and nursing that come out to your house for the first 2 weeks after surgery. With hip replacement in particular, I don't usually find that you need outpatient physical therapy after that initial 2 weeks. It's different from person to person based on your strength and your pain level. Most people take the pain medicine that I prescribe for them before surgery for about 2 days or up to 4 to 6 weeks after surgery, gradually tapering down as they go. It all depends on the person, and it also depends on how much pain medicine you were taking before surgery. I hope this was helpful. If you have any other comments or topics you'd like me to discuss, please feel free to put them below, and if there's enough interest, then I'll go ahead and make another video. Have a good day.